Ladies and gentlemen, this is the part of the evening that everyone has been waiting for. I know people will be filtering in, but we're gonna get started here. And the first person I'm going to introduce, who will introduce the rest of everyone, is someone who I've known for a very long time. She's known me since I was very young, and I'm just so happy to be able to work with her. The first time I saw her do a moderation, I was, and thank you to the Canadian Foundation of Pharmacy for helping sending me to Copenhagen, and I watched her do an incredible moderation in Copenhagen at a pharmacy conference. To see somebody of that caliber come help us here at our local association, it really means the world to us. But I can talk on and on about her, but I think I'd let her take the front center stage. Put your hands together for our moderator, Sheli Dattani.
Thank you. I thought you were talking about Nardine. Okay. Hi, everybody. We're seeing folks still trickling in. How many of you, I am going to introduce our panelists, but how many of you remember Blockbuster? Show of hands up high. Okay, and you remember going every Friday night to Blockbuster to get the video, right? Well, in about 2000, Netflix offered to purchase Blockbuster. And Blockbuster said no. They laughed them out of the room because their whole business model was based on what? Does anybody remember? You remember when you return that video late, you're paying that late fee? So that whole business model was based on late fees. In 2010, Blockbuster was out of business. No more going to that blue and yellow store. There was streaming happening. Netflix had taken off. When you're funded as a video store, you can't think like a streaming service. So we don't know who our Netflix is in Canada yet for pharmacy, but we do know who Amazon is. And we know that Amazon is already delivering prescriptions in the US. We also know that Amazon has already a trademark in Canada. They're waiting at the door. They've got lots of regulatory hurdles because we are Canada, right? So they're gonna have to pass all these provincial regulatory hurdles. I don't know, Ali, you probably know this more than I do. But it's going to be a while, but it's coming. So the pharmacy that stays a dispensary, this is about moving out of the dispensary and into the clinic, right? We've talked a lot about that today with some great clinical talks. But the pharmacy who stays in the dispensary, or even like pretends under the guise of being in the clinic, but who really stays in the dispensary, is not going to be, well, we'll let you think about that. In a streaming world, we don't know where they will be. But certainly there is a destination that we're all trying to move towards. We're trying to move towards a primary care destination, and I think we all want to be there based on what I've heard, at least today. So my name is Sheli, Shelita, my friends call me Sheli. I've worked for 2 national advocacy organizations in executive roles. I'm not here in that capacity. I'm not representing any advocacy organization, any board of any advocacy organization. There's lots of OPA former and current board members here, some on the panel who will be answering some great questions, but I'm just here as a person who cares about the profession, and I'm an advocate for good care, good health care, because I feel like we live in sick care right now in this country, and so we're gonna get into that. So let's get into it. So we have, I think most of you know all the people on the panel. To my immediate left is Sean Simpson. Sean, a few years ago, we had some fun on a similar panel. Sean is going to make pharmacy great again. He may use some Donald Trump analogies in the most positive way, but he's our realist and our provocateur, and I'm going to count on him to provoke us in this panel. Nardine needs no introduction, so I'm not going to read bios, but Nardine is I'll call her our minor ailments architect. And our academic, she has very academic glasses on right now, so she's going to give her, and as she takes them off, she's going to give us her perspective. We have Hitesh. Hitesh knows the system. Hitesh is the chair of the OPA board. Hitesh is also a mogul. He owns several pharmacies, and he understands what operationalizing care looks like and how to sell that and talk about that to government. And we have Stacey, who was kind enough to join us at the last minute, but she's actually the perfect addition to this panel because Stacey provides a different type of care, and I would argue that it's also primary care. And we'll talk a little bit about what Stacey does. Excuse me, allergies really bad in Ottawa, also bad here, as we get into it. So the first question I'm going to ask, I'm going to think I'll start with, who will I start with? I'll start with Sean. Lucky Sean. So we're going to talk about the moment finding the permission slip, right? So no one gives you a permission slip to be a clinician. And by the way, no one should give you a permission slip not to be a clinician, right? Not government, not the patient who says, can you do that? Certainly not the physician prescriber who says, is this within your scope? It's yours to give, I think. So, Sean, what was the moment when you realized that the dispensary, the proverbial dispensary, was just the starting point in the care that you provide to patients? Do you remember what that was?
Thanks, Sheli. There has been multiple, for sure. But I think, we think of pharmacy as filling prescriptions, and that's what we do. We want to know how many scripts a day we did. But embedded in those prescriptions and those numbers are encounters. And so it's been aggregate almost 20 years in practice now, so I can think of a few times that it's mattered. But what resonates most is times where you're helping somebody and you help them navigate something that they never even thought. And the one that resonates for me wasn't even a prescription, it was an OTC encounter. It was a friend came in, wanted a recommendation for a probiotic, and started talking about their bowel movements, which everybody loves talking to their friends about bowel movements, of course, but through that it was like, geez, maybe you really should get checked out. Like, this isn't normal. I don't think this is a probiotic. I think maybe you should take a probiotic, and this is the one I recommend for you, but I really do think you should go and get checked out and go see your doctor. And I was glad about that, because it turned out that he did have colon cancer, and it hits home, because then you realize that had you not been there, you don't know what could have happened. So that's one.
Oh my gosh, that's amazing. Thank you for sharing that. And clearly that's still, I feel like I have to give this guy a hug right now. That's going to always resonate with you. I think so many of us have those moments. And Sean, I know you cut your teeth in your dad's pharmacy, as did I, in your family pharmacy. Stacey, you did too. You're a second generation pharmacist. What was your moment, Stacey?
Yeah, it's interesting you ask, because that was one of the first things that came to mind. Is I also grew up in a family of pharmacists and grew up literally working in the pharmacy, and I always saw care and relationships, but it was always very product focused for a long time growing up. And I think I went to school at a very pivotal time, 2009 to 2012, so that was one of the times where we were just getting paid pharmacy services. The meds check program was starting to come out, flu shots were being enabled. So that was very kind of pivotal in opening my eyes upon graduation of what the future could be. But one of the most influential things that brought me to where I am today and really got me to broaden my vision in terms of what's possible for pharmacy practice was later in my career. I owned a pharmacy and an integrative clinic. And in that opportunity, I got to work with practitioners outside of pharmacy. So we had a naturopathic doctor, 3 naturopathic doctors, nurse practitioner, massage therapy, holistic nutrition, all kind of practicing delivering healthcare outside of the OHIP-funded model. And that really, like being so close to their practice, seeing the way they delivered health, the value that people saw that they provided, and their ability to disconnect from this pressure that I think we all feel in pharmacy to give things away for free or to get it covered under the public system, and just really provide good care and provide service that's of value and not be afraid to charge. That really opened my eyes into what's possible in terms of service delivery for pharmacists.
And we'll get into the funding in a little bit and some of the care you provide, but both of you are telling me that you just took this on your own. No one said to me, go ahead, let me nudge you, like be clinical, be a clinician, that's who you are, right? So thank you for that, Stacey. What about you, Hitesh? Did you have a moment, sorry, you'll have to pass over the mic. Do you have a moment that you can remember?
Was, when I actually first started practicing. I'm very fortunate, Varsha's here. She was the first pharmacist that I've ever worked in my life, right? Varsha, we go back a long way in a very community environment, right in the middle of Burlington. And, that was the start of my pharmacy career. I see Farouk here is my pharmacy manager from who started literally a fertility program within our community. So those were the wake-up calls for me. It's just being inspired by people like this and that we can do more. But really the eye-opening experience was during the pandemic where, we were doing COVID testing, we were doing COVID vaccines. Our practices, our pharmacies were healthcare hubs. And really that's the message that I go back to government all the time. When we go for more scope, we look for more expansion, more funding. It's the concept of that we are a healthcare hub, and how do we expand on that model?
Absolutely, and we always have been. I mean, my dad was a healthcare hub in the 70s and the 80s, and his pharmacy, when there were no pharmacy services, I couldn't believe what he did. And he really opened people's eyes, and he didn't ask for permission either. Nardine, did you have a specific moment in mind where things just turned for you? Or maybe it was the beginning?
It's on. Oh, okay. Yeah, I mean, similar to Sean's, I think I started out in New York, which is where I'm from. Please don't hate me. And where I practiced there, there were a lot of patients who would come by and ask for help because they simply couldn't afford to go see a physician. They couldn't afford the cost of healthcare. So they would come to the pharmacy looking to treat things that were oftentimes really not minor, very much chronic or serious. And I had to be really creative about the strategies and the plan that I would give each person because I knew even if I said, you need to go see a doctor, they're not going to. So I made it my mission to really find evidence behind over-the-counter products, natural health products that did have proof of efficacy and safety for them. But what I realized is patients weren't really looking for a product when they came in. They were looking for a plan. They were looking for somebody who would listen and a plan. And that's what I was able to provide. And, in New York, pharmacists have very, very limited scopes in comparison to any pharmacists in Canada. And so now that we have a greater scope, I think that's really just been incredible to witness that transformation from, they still want a plan, but now the plan and my tools in my toolbox are just so much more vast than they were before. But it was definitely early on in my career and very much OTC consults that made me realize just that the value is so much more than the dispensary and the prescriptions. It's really in having those one-on-one encounters and creating care plans that were individualized that could improve their quality of life.
Yeah, I mean, Nardine, you've been such a pioneer in guided self-care, and it's not, I love what you said, it's not a product, it's a plan. And again, you didn't wait for somebody to say, you can do this, you should do this, you just did it. And so many of you did this before we were allowed or permitted or somebody gave us permission. Pharmacists love to wait for permission, right? So I think we're showing now that we are going to take what we know we can do. Nardine, I'm going to keep it with you for a second because I think we talk a lot about being primary care providers and we consider ourselves primary care providers. I'm going to say something a little bit provocative. Does anybody else see us as primary care providers? I feel like including this room, and I've said this a few times over the last few years, is sometimes I feel like we're a bit of an echo chamber. We talk to ourselves. We preach to the converted. We are doing a lot of work, our associations, everybody else, and talking to external folks. But do we feel, if we asked others, if we asked Holly in the room or other people who aren't pharmacists, sorry, Holly, I'm looking at you right now. So do you actually think your pharmacist is a primary care provider? Maybe they do post-pandemic, but what do we think others think of us? Nardine, you go first.
That's a great question. I think patients absolutely see us as primary care providers, and that's evidenced by the fact that over 2 million of them have visited pharmacies to get minor ailment services. So they're coming to us for this service. They see us as kind of this, but I don't know that we think that of ourselves. I think I have a lot of students that I train, and a lot of the students who will see, I need you to go see a primary care provider, go see somebody else. And it's the mentality of, what's the difference between another primary care provider and you, right? And so now we We do this whole thing where we differentiate what type of care that individual needs to see whose scope it falls under, and look at it that way, because we don't often see ourselves as primary care providers. And I think if you're not able to clearly articulate what it is you do and what it falls under, then you can't expect others to understand that or to appreciate it.
That is a very interesting way to sort of flip that script, right? Like, do we say we are, but can we really convey what we do as primary care providers? And we have to identify ourselves that way before others can. I think that's a really good point. Stacey, so you talked a little bit about what you do and some of the out-of-the-box work you do, and patients are willing to pay out of pocket for that work. So you didn't wait for the healthcare system to validate you as a primary care provider, yet a lot of the work that you do is optimizing medication therapy and customizing people's medication needs to their values and preferences or whatever it is. Talk to me a little bit about that. Do you feel that those people that you treat see you as a primary care provider?
Yeah, absolutely. I think people definitely value the care, and I don't know if I would necessarily use for myself personally the primary care provider, but absolutely a clinician. And I think probably the same goes for many pharmacists, even in hospital pharmacy, for example, which is not necessarily primary care, but to approach it with a real clinician mindset, and the fact that your goal is to be there and to help people. I think from a broad system perspective, we're kind of in this in-between where I think it really depends who you ask. One person could say, yes, I see my pharmacist. It depends on the experience that they've had in terms of like their interactions with a pharmacist. And I think the more we can get our own identity as a clinician, as a primary care provider, and provide that consistent experience across the board, that public system perspective will follow. So I think really it's our job to step into that identity and that role, and the rest will come.
Very good. So similar to what Nardine said, is we have to claim that identity, and many of us claim it maybe a bit too much and identify very closely as the pharmacist that we are in every, certainly I feel like I do everywhere I go. I identify first as a pharmacist. By the way, I'm a pharmacist. Can I help you? So I think, but we have to, I think further and think about the care we're providing today and how we identify ourselves. Hitesh, you've been working a lot with OPA, with government recently. There is a primary care crisis across the globe, in this country, in Ontario. We have a lot of money, though, being allocated to primary care action. We have Jane Philpott. We have lots happening. We know pharmacists have been named. Hopefully they'll be involved. How do you create that connect between the fact that we already have this ready-built infrastructure in every community, whether it's your pharmacy in downtown Toronto or Kristen's pharmacy or whoever else's it is, and that we already have built-in infrastructure for the primary care integration, if you will, and expansion that Ontario is trying to strive towards in the next 3 or 4 years?
Absolutely considered as primary care health providers with government. I think when we start talking about talking to politicians, they really recognize that. They really appreciate that. What we need to stop doing is doing things for free. And so the issue that really, when I start talking about adaptations and prescription renewals that we're doing every day, part of our workflow, and we're doing it for free. So my job is really to advocate for that and really go back to government and say, we're doing these things. We're looking at MedChecks reform as an example right now, and we're saying, there's a bucket of money that's allocated to this. What can we do to cover for these services that we're providing for free? So that's real. That's where advocacy comes into play, and that's where we really need to reinforce what pharmacists can do and what we can provide for. So.
I'm going to segue, and then Sean, I'll bring it back to you, but you've led me into the next question, which is really around, we have delivered care for free for decades. We've been doing minor assessment Isn't that interesting? Minor ailments assessments for a number of decades and leading people, like Siva would say, signposting to the emergency department or the OTC aisle or whatever it is that you're doing for that patient. We've been doing it for free for decades, and yes, that can get devalued. Some pharmacies will do things for free as a survival strategy. When the funding doesn't follow the scope that we have, thinking about this in terms of the person in front of us, Sean, what does the patient lose when funding doesn't follow scope?
That's a great question. I think, I don't know if that's on. Is it on or not on?
Not on, you just talk loud.
You turned it off? Huh? Got it. 9 years later, she still
Trauma
holds a
from
grudge.
it.
It's a great question, and I reflect on this, and I think back to when I first started practice and where funding was, because as Stacey said, we just started meds checks at the time, and we just started, but what was happening at that time is they hadn't pulled back or clawed back some of those other nondescript funding resources that were there. And it actually made it easier for us to provide quality comprehensive care because we knew that that backdrop was there. And I don't want to pick on my colleague from Dryden, who definitely traveled the longest to be here, but we had a great chat yesterday, and as a new practitioner coming in, you know, the comment was like, I don't understand how we make money in pharmacy. I don't know what the reimbursement model is. The markup is nothing. The fee is just there. And so we walked basically quickly through, like, you know, sort of these are where the hidden dollars are, and, you know, and then the generic markup. And it was much more lucrative back in the day, and I think it afforded us so much more opportunity to be able to liberally apply ourselves in the name of good care for the patient. And the one challenge I think we have now is that we've gone to this menu system where everything's itemized and everything's costed out, and it really, like, it's overwhelming at the time to figure out, okay, I can do this, I've got to pull from this menu and there, and this is, I'm going to do the adaptation, or I'm going to do the extension, or I'm going to do this, what do we call it, the pharmaceutical opinion, or it's a minor ailment. Like, it's just not, it becomes fragmented care because of those challenges. And so it would really be nice, because I definitely do see ourselves as primary care providers, but I almost want to say it was easier 20 years ago than it is today.
Yeah, that's an interesting perspective, and I think that, you know, the other thing that it makes me think of, well, it makes me think of two things. One is that, are we subsidizing some of the other care we're providing through our dispensing, which many of us will say we are, right? And the other thing I think about, and maybe I'll turn it to Nardine and then Hitesh, if we are primary care providers and we're being paid out of a drug budget, and it's a constantly what piece of the pie conversation, how do we get into the right envelope? Is there a different envelope? This is a big question, but, you know, maybe Hitesh wants to start first. And who's got to make that first move? So if we are primary care providers, we're going to claim that. We're going to be at those tables where this is being discussed right now in Ontario. How do we look at, you know, and this is always the big question, is what budget do we really need to get paid out of?
Answers that because she has the academic background to this. Our biggest strength is the success of the minor ailment program. It is incredible.
Talk into the microphone just a little bit.
Sorry.
Just closer.
Our biggest success has been, from a services perspective, has been the success of the minor ailment program. And how do we expand on that? And how do we use data to support government to come back to us and say, you can do more? Because we are always out there saying, we can do more. We want to do more. The minor ailment program is specifically data-driven. And so, you know, I'll pass it back on to Nardine, but I think really when I talk to government, when I talk to the Minister of Health, they're so happy and so proud of the minor ailment program. It comes up every time I talk to government.
Yeah, Thank you for that. I appreciate it. I will say one thing. I was really nervous when we did all that work on the Minor Ailments Advisory Group for OCP that it was not going to become a funded program. And as soon as I found out there was funding, and we had advocated for funding for your assessment, not the results of the assessment, not the prescribing piece, I was really happy because at the end of the day, a funded service is a sustainable service. And sustainability will do something else. It will ensure continuity of care, like Sean said. It's going to ensure there's no fragmentation there because you're going to do it more often. And that continuity of care is going to ensure that patients are getting comprehensive care, not falling in between the cracks, and that's going to ensure that you're turning the transaction into a relationship. And that kind of relationship is what's going to deliver the best type of quality primary care. And so I say that because that's what we're getting out of this minor ailment program. It is a funded program. And so because of that, now we're getting these quality interactions. How do I know they're quality? We're tracking outcomes. So we have outcomes. We just published a white paper on it, over 250,000 patients that were in MapFlow, and we looked at the percentage of them who either had full symptom resolution at follow-up or significant improvement of symptoms at follow-up. And the number is 97.8%. And so that is wow, and that's a testament to all of you and the work that you're doing. The national average, and the last time it was ever looked at was out of Saskatchewan over 20 years ago, and the average was an 80.8%. So we are well above the national average, and I can tell you not a lot of professions track their outcomes to care. Well, like, when's the last time your doctor called you to say, hey, that antibiotic that I gave you for X, how did you do? Did you have full symptom resolution? Did you develop adverse effects? Nobody does that. Yeah. So we don't even have the outcomes of care to compare it. We have ours, and that's why that data is so vital. We are working now with MapFlow. We're empowering other associations outside of Ontario as well as OPA, of course, and working with them to generate that data so they could take it back to the associations, because data speaks volumes. And the data and the success that you're speaking about for minor ailment program, it really does showcase, the full range of our abilities, our knowledge and our skills as pharmacists. And that's what's going to move us forward. And I think we need to keep generating this data, and we need the patients to also come in and speak to the service and the quality of care that they receive, so that it can again just open up other doors. But you're right. I think we need to really use this as an anchor for continuing to build our scope.
That's a good word. Yes, Hitesh, I know you're chomping at the bit.
What patience is the key. I completely agree. But from my perspective, taking this to the next level is going to government and saying, this is the success of the program. This is what we can do. How do you fund us? So it's really going back to, sort of the grassroots of funding, and how do you fund? So one of the things that I say to government all the time, I say, minor ailment program is great, and it the $19 that we get for an ailment, it's fantastic. It does not fund a pharmacist working there, sitting there all day. That's not a funding mechanism. We're losing money on having this one pharmacist sit there to run sort of a clinic model. So from an advocacy perspective, we're very much about, give us more so that we can have that clinician, we can have that pharmacist dedicated to clinical services, and that brings us to the notion of clinics and the clinical model, and we can talk about that further. So.
Yeah, we have extra time, so we're going to talk about all of it. But I'm just going to round out what a couple of you said so nicely. So Hitesh, starting with you, absolutely, I think, and that's what we'll have to turn off our phones, I think. Hopefully it's not my child trying to FaceTime me again. I think that's what I meant before about subsidizing some of this through dispensing or other models. Like $18 is not enough, right? What I love about what Nardine said too, and every time probably still every 3 weeks I get this question, but being paid for assessment is really, really critical. It negates the conflict of interest arguments and all of the other things that, people will say in terms of assessing, prescribing, dispensing all in the same store. That patient has a right to go wherever they want. You are paid for an assessment. That's value. That's tremendous. I think too, Nardine and Hitesh, what you touched on as well is in other provinces where minor ailments or other scopes of practice have been funded for years, have been activated, but not activated through funding, they don't go anywhere, right? Manitoba, we were talking about this last night, Amy, with minor ailments in Manitoba, right? In the Atlantic, they had minor ailments for a number of years, but they weren't funded and things didn't really get moving until the pandemic, right? So I think that we definitely have to get paid for what we do. My bigger question was, out of what pocket should we get paid? Out of a primary care fund? Should we continue to be paid out of the drug budget? That's a wicked question. We don't have to answer it now, but I think it's something that we need, we all talk about and continue to think about. Stacey, you again are sort of in an environment where, as we said, there is no public funding pathway for what you do. Is that a model that works? We touched on this a little bit a minute ago, but what does it mean for that patient who has to pay out of pocket? Because many of us are asking people to pay out of pocket for things.
Yes, thank you. I'm glad you asked. I hope that pharmacists can see the success with minor ailments and be inspired to think outside the box in terms of what other services you could provide to patients that deliver value to them and that you love to give. I think we all, if you look at the history, the windy history of pharmacy, and just like a lot of us kind of practice within our box of our profession, which has historically given a lot away for free, we feel the confines of like, the funding has to come or the structure has to come and then I can deliver it. But I can assure you that people are willing to pay for their health. And they are paying for their health. They're paying for dental work. They're paying to see a naturopath. They're paying for supplement stack that's like, hundreds of dollars a month. They're paying for weight loss programs and prescriptions for weight loss that you see quite often. And people are willing to pay when you're providing something of value. It's just a matter of thinking about what that could be for you. I also know a lot of pharmacists are burnt out and feeling a lot of lack of meaning and purpose, and so I just would encourage people to use this as an opportunity to, maybe it's another income stream, or maybe it's bringing revenue to your pharmacy, or it could bring so many possibilities, but I just hope that people open their minds to what could be, because patients are willing to pay, they will pay, from a patient pay perspective, so that's my main practice. Patients do pay out of pocket, but just as a kind of a tidbit to throw out there that you can share is that unfortunately we're not covered under the traditional private insurer bucket right now. I would love for that to change, and Sheli and I were chatting about advocacy potentially in the future, but you can go to a massage therapist and get that paid under traditional private insurance, but not a pharmacist, unfortunately, at this time. But if they have a health spending account or a wellness account, which more and more private insurers are starting to offer because it's a huge benefit, and in terms of HR, they're starting to apply these buckets, they can definitely get reimbursement for your services through there. And barring that, they can also, your services are considered a medical tax credit across Canada. So just even saying that helps people to make a decision as to whether whatever you're providing, $200 for a consultation or something like that, is worth it.
Yeah, no, that's good, Stacey. I think about even in the vaccine space, like there's data that demonstrates, we ask whether it's to pay out of pocket for their vaccine or a vaccine admin fee. There's really good data that says that, physicians will not recommend vaccines to patients because they're not funded. So like, let's take RSV under 75 in Ontario, just for an example. And the data actually shows that the number one reason a person will pay out of pocket for a vaccine is because their healthcare provider recommended it. So there's a disconnect there. So I think there's even evidence in the literature that suggests that don't assume that the patient won't. Obviously, we want the public payer to be out there, but there's certainly that evidence. So I think that's really important. But I think valuing and perception of value is often still through in Canada. It's Canada. I want my healthcare for free and I want this paid. So I think there is a perception of value that we need to be, thinking about as well. Hitesh, go ahead.
You talked about, being part of the drug budget and where does funding come from. I'd urge everyone to think about this. Be careful of that because it's a blessing and a curse to be a part of the drug budget, right? So, and principally, the reason behind this is pharmacists are not good at outcomes. We are not good at showing outcomes. And so you want to be a part of a different budget, we need to be able to show outcomes, and we need to do outcomes research. And that's where Nardine comes in, and plug into Nardine, sorry.
Yeah, we'll get to Nardine again. But you bring a really important point. It kind of leads into my next question. Because if you're part of another drug budget, like if you're part of the primary care budget, and we are, for example, there are different challenges, different opportunities, but also a whole slew of different challenges of money that other people are also fighting for, right? So I think you're right. It's a blessing and a curse in so many different ways to think about what budget our care and our services, not the product we're dispensing, should be part of. The other question I sort of wanted to touch on with you guys is, scope is expanding in this province. It's fantastic. We're going to get more this year. Advocacy, this, Hitesh, Nardine, Sean, Kristen, all of you guys know that advocacy is a long, long game, and it takes, I think minor ailments has been like a 12-year, Sean, you probably remember this, right? Advocacy fight here in this province. Let's just check the engine, though, before we continue to hit the road on scope. And we touched on funding quite a bit. But what are some of the other maybe guardrails that are actually roadblocks to us moving forward in scope? So we talked about funding, so let's kind of move away from that. But Nardine, what are some of the others that you see in the minor ailment space or the broader scope space that are roadblocks?
I mean, there's a lot of roadblocks. I think, lack of integration, lots of, different platforms. But I think at the end of the day, a lot of it is infrastructure. And I spoke about this last weekend at a different conference, but lacking an infrastructure to enable you to scale is always going to be the biggest barrier, in my opinion. And so having that infrastructure, ensuring that your whole team is part of the delivery of the service and has the same vision, or is at least following kind of the same plan, because one person doing everything is never going to work. So in one word, my answer is infrastructure.
Very good. Infrastructure. Okay. Sean, can you help us dig a little bit deeper into that, what that means if you choose that word, or another roadblock that you see? What's the challenge right now?
Yeah, I think building on infrastructure, more concrete examples are access to a common medical record. And like Clinical Connect is available, but it's really difficult to access, and it's a pain in the rear end. And I would argue that hardly anybody, even if you do have access, finds it that easy. And I know Siva will jump through hoops to get it, but I know that he is more diligent than I am, and I find it exceedingly difficult in order to do that. And I think through the lab work network, all of these things make it difficult. And we've even seen, the failed attempt at Prescribe It, or Prescribe IT, which is, an infrastructure project which was ill-conceived from the very beginning, and tons of money was invested into this, because it was going to provide a messaging platform for us to expedite care, and it didn't really materialize. But these are where these gaps still exist, that we are primary care providers, and we can provide that care, but the infrastructure is right. There are all these missing pieces that make it so difficult for us, because we need those tools in order to be able to proficiently provide care.
100%. I think Prescribe It had about a 5% or something physician uptake. So in other countries, these things have been mandated, which, in the U.S., one thing that the U.S. does better than us, right, which is that sort of registry piece that connects us all together, labs, more broad registries, a big fan. I think, you made me think of something else. Now I lost the train of thought. Oh, yeah, we were talking about this last night. is in some provinces, like in Nova Scotia, I believe it's, whether it's mandated or it happens a lot, is that physicians will write the indication of whatever that patient's taking that medication for on the prescription, which is, it'd be great to see that in a record as well, right? So there's lots of missing pieces to the puzzle when we're practicing. Really good point. Hitesh, for you, when we're at the table with government at OPA, how do you convince them that removing some of these roadblocks isn't just a win for pharmacists? It's a win for, obviously, for patients. It's a win for workflow. It's a win for staffing. We could just, work in such a better, seamless way if we had some of these roadblocks removed, some of the ones that we mentioned.
Really from an advocacy perspective, and I have Kristen backs me up all the way here, it's full scope. There's no, this notion of doing 19 minor elements and then adding 14 more, going into legislative changes and going into all this, we want full scope. There's provinces that have done it really well. Alberta is an example. Nova Scotia is following now. We have incredible examples of jurisdictions who have done this phenomenally well, and that's our position at OPA. We really want to push for full scope. I say this in meetings all the time with government, which is, we are going back and forth all the time. Let's just have one conversation, full scope. And full scope, according to Kristen, is full prescribing authority. And why not? We have it in other provinces, right? And we have
full scope with funding, right? Because we have had full scope in many provinces for many years, and it hasn't been activated. Because why would you do something and not get paid for it? Sorry, I'm being a bit opinionated, but what do you, I'm going to ask another sort of, Stacey, maybe I'll ask you this question. From your vantage point, what about protectionism? What about turf? Is that still a barrier, or is it getting better in this province?
So that's a great question.
From your vantage point.
From my vantage point, yeah. So some of you may know that my main focus of my business is around deprescribing, and even though in theory I could prescribe within my scope to adjust a dose, I actually never do, because my work is fee for service and I want to ensure that the patient has continuity of care. So I'm always collaborating with their original prescriber and writing consult notes. And so when I explain this to patients and whoever's involved, that's always one of the questions that I get is like, well, are prescribers pushing back? Or I've knock on wood, because I could have a disgruntled person disagree, but so far I have 100% success rate. But people, prescribers are not always communicating back. They just implement my plan. And so I get that feedback from the patient. So I guess in terms of, I think people are willing, practitioners are willing to collaborate, but they're not necessarily fully closing the gap in terms of the communication in a way that I wish was more collaborative. This also kind of came to mind when you were mentioning that primary care physicians may not recommend something that's fee for service, like for example, a vaccine, for example, sometimes. I also have the same experience from my vantage point. 90% of my business is by referral, but not from GPs or primary care providers. It's all from allied health providers or specialists. So psychiatrists, psychologists, psychotherapists, naturopathic doctors, all of these allied health professionals. And I also feel that there's just kind of this barrier within their kind of, I don't know if it's culture or just experience, that there's a hesitancy to recommend, even if it might benefit a patient, but if it's not OHIP funded or if it's not covered.
So interesting, Because I bet, Siva, your experience at the family health team, certainly mine, was a lot of deprescribing, because you're right there. And that's a whole other thing we could talk about being co-located and awareness and how they can effectively use you and if they have time and what they should do. Sean, do you see sort of protectionism and turf from other healthcare providers, even nurse practitioners, primary care physicians, since scope has continued to evolve with funding? Where do you see that from your vantage point now?
Yeah, it still exists. I think, I sat in a lunch with the group of doctors in our clinic a few weeks ago, and I would say it's changed. I think there's, 7 out of 8 are probably much more willing and able to work and collaborate, but there's one that's still resistant. So I think the pattern's shifting, but it's the turf still exists, and we need to overcome that. But yeah, it's a problem. Like it's not necessarily going to go away, but I think we've made huge strides towards winning over our physician colleagues and our nurse practitioner colleagues, and many of them do rely on us so heavily for our recommendations and our insights and our care. So it's there, but it won't go away. And even at the advocacy level, we know when OPA goes and tries to advocate for things for our profession, we know that there's somebody on the other side of the OMA desk sitting there going, nah, you probably shouldn't do that. And so there's as long as there's vested interest, there's probably going to be that in play.
Yeah, Nardine, go ahead.
I will say I've had a number of conversations over the past couple of years with pharmacists who'll say to me, "Hey, I don't do minor ailments," and my question will be, "Why not?" They're like, "Well, I'm connected to a physician's office, or I'm in the same building," and so they said, "No, I'm not allowed to." Most recently, a pharmacist told me that it was written in her lease agreement that she could have the pharmacy there as long as she does not provide competing services, and they listed the services, and minor ailments was one of them. She's like, "What do I do?" I'm like, "Say no," right? Like so yes, it still exists, certainly, but I think there's strategies to help with this. Number one, I'll say there's a lot of misinformation out there. So just making sure that the physicians know that they're not going to get dinged if they're a part of a family health team and they see if their patient sees a pharmacist. That's something they're not aware of. Number two, they always want to know what our fee is. They just want to make sure they're higher. Let them know. Give it to them. Once they know it's $15 or $19, they calm down a little bit. And the conversation, really, that's been my experience. Number three is, just because you're in the same building with physicians or a practice does not mean you can't provide this service. Find a compromise, even though you don't have to. Really, you have to work with these people anyway, so find a compromise. And what I've seen really successful stores do is they'll say, physicians close at 5, I will do a walk-in minor ailment clinic from 5 to 9. Sure, go for it. Start there. Or say, I will be providing these services, but for your patients, I will not give more than one refill, and I'll make sure you are notified. Like there's continuity of care, that you're notified within 24 hours. So oftentimes that's part of their concern, is that they don't know what's changed with the therapy. And if the patient goes to see another doctor, they may never know what's happened, but you can kind of tell them that you will give them the courtesy of letting them know what will change, if anything, within a certain time frame, and they're better when they know there's boundaries, right? And that you're so I just think I agree with Sean. I think that it absolutely exists, and maybe there's a little bit more out there who are kind of who can buy into this, but there's more that we can do, and I think just making sure they're aware that we have boundaries to our scope. Most recently, dermatology advisory board with a bunch of dermatologists who thought that pharmacists who could prescribe for acne could prescribe Accutane, and they were very concerned about that. They were up in arms, and I was like, well, we can't. We're limited to topicals. They're like, oh, then yeah, go for it. Absolutely, topicals, go for it, right? So oftentimes they don't know. They have not been briefed by OMA on here are the categories of drugs, and so that is our job to do that. It's to let them know, and then work with them on a plan, just to get their buy-in.
I think both of you have touched on some really good points, and then Hitesh, I'll turn it back over to you. I mean, I have issues with the lists and categories of drugs in general anyway, but again, that's another conversation. But I think sometimes it's just about awareness and communication. That's a bit of a theme on this panel, right? Like Stacey, you said it, and Sean and Nardine, you said it. I mean, even when minor ailments start, and I was at the FIT, people would be like texting me examples through the EHR and saying, look at this, I don't know what they're thinking. And really, it wasn't about scope or ability. It was about either the note is way too short, so they're just, it's just like anything else. It's a paradigm shift in understanding. When the pharmacist just says nitrofurantoin initiated, they don't really know, or they don't have that trust yet. And so it becomes just about communication. Either the SOAP note's way too short or it's way too long. So I found it was, hey, maybe there's just a coaching opportunity here to talk about what good communication looks like as you're transferring over care of your mutual patient. So it can be that simple sometimes. I think the misinformation thing is really true. Hitesh, go ahead. Do you want to add something?
You know what? honestly, from a advocacy perspective, absolutely OMA is going to oppose every scope that we propose. That's their job. Our job is really to have that relationship with that physician, what we do every day. Like, one of my stores is right in the middle of Hospital Row, right on University, and we are part of the triage system. You have a UTI, go and see the pharmacist. Why are you waiting in Emerge, right? So it's building that relationship. Yeah. You know, we have to get over OMA because they're they have more money than we can ever have. Yeah. They have a huge advocacy, they have a huge front, but not all physicians agree with OMA. There are, you know, when you have that relationship, when you work with that physician one-on-one and they understand what you're doing and your model and your clinic model, you will have that support. So, you know, get over OMA. It's okay. We can deal with them. We'll always deal with them. Yeah. They're our friends, and we know how to deal with them. Kristen knows how to deal with them.
I don't know if they're our friends, but I think you're right, though. The rank and file, most physicians that all of you work with, I would think at this stage are, with the exception of a few of those loud voices, they are still there, and they're not all the, you know, people who are just near retirement. They're younger folks too, but I think most people are ready to think about it. I think also, you know, the OMA is a union. There's a lot of deference to big organizations like this with government, but remember the permission slip, right? Like, they do not have purview over what we can do in our scope, and I think we get caught up in that still a bit too much. There is one person that should have more power and more direction into care, and that's the patient, right? So the patients are here, and they've been waiting. It's like, Kristen, you said this in your travel talk, is, you know, they don't know what minor ailment. I don't even remember what of the 19. They're just here wanting care. And you need to give them the care, and you need to give the persuasive ask and create the expectation, teach them how to receive care from you. But when you have 2.5 million Ontarians waiting for a family doctor, you have a primary care action plan in Ontario, but what is it to get everybody attached? I think by 2029, is that right, or something like that? In the interim, these people need care. So people want, and minor ailments, Nardine has shown us that they will show up, you know, when we provide the care. Even in provinces like BC, who were the last holdouts for minor ailments, saw the reduction in emerge visits in real time, which is an economic case in real time, just like they saw in Nova Scotia with the 10% decrease. What do we do? Sorry, I'm rambling a bit, but like, well, I'm not going to tell you what I believe. Do we underutilize Ontarians as the strongest political hammer that we might have in this? Hitesh and then Nardine, your comments.
I think we need to focus on this notion that we have already, which is we're a healthcare hub. And yes, we're doing a lot of services, and we're doing a lot of things for free, and that's the start. From an advocacy perspective, that's the start. We're doing all these things. We're a healthcare hub. We are going to be part of that solution, and then move into the next phase of discussions, which is funding. But I think we do this every day. Our pharmacies are healthcare hubs today. We have patients waiting for prescriptions, very rarely, because we just text message them when the prescriptions are ready. So patients who are waiting in our pharmacies are not necessarily waiting for prescriptions. They're waiting for services. They're waiting to speak to the pharmacist. Yeah. And I think that's very crucial, and we need to pivot on that.
So Nardine, when you're at dance class with your daughter and you're talking to the moms about the healthcare hubs, what's the mom's job? Like, what do Ontarians need to be doing if they really like coming to see their pharmacist for this care? I know that's not what you were going to say.
Yeah,
so go ahead.
My daughter hates dance. I was going to say something else, but that's a really good question, Sheli, so I'll address it as well. I think I said this to this group maybe last year, I'm not sure, but I had something happen when I went to get my tire changed last year. So I went to, I had a flat tire, went to get it changed, and the individual who was changing my tires, I told you this one, right? The guy looked at me, he's like, what do you do for a living? I said, I'm a pharmacist. He's like, oh, are you one of those special shoppers pharmacists? I'm like, I don't know.
No, that's
what's that?
Hitesh.
I said, what's that, right? And he said, one of those special shoppers, drug mart pharmacists who can like prescribe medications. I'm like, no, I'm not one of them. I'm not. And at that moment, I was like, wow, right? Some shoppers is doing something right to have that kind of image being reflected. Like, you are a Shoppers Drug Mart pharmacist who is like special, and everybody, I was like, no, I'm not. He's like, oh, you should try to be one of them. I said, yep, thanks for the feedback, right? And I just think there's a lot to learn there. What are we doing to get the word out about our pharmacies? And what can we learn from a Shoppers Drug Mart, head office, obviously, who has a lot of money to spend on marketing and advertising. But I think we could collectively come together and do more to tell our patients about the services we're providing and be seen in that same light, right? I think there's something super powerful about that. And my daughter and her friends and their moms, a lot of them will say, I went to Shoppers, or I went to this pharmacy down the street. I didn't go to my independent because I know that these people will offer it, and it's just all about the marketing and the advertising and the word of mouth.
Well, I think perception is everything. It reminds me of Alberta when, they started opening their pharmacy care clinics in Lethbridge and in other places. People actually had no idea that they had this scope since 2000 and, what year was it? 7? And they're like, did you know my pharmacist can prescribe in 2025? Yeah, they've been able to do that for 20 years, but because there's a bed and a waiting room and 2 separate workflows, it actually matters, right? Perception is everything. You go into a Sean's pharmacy I keep picking on people I'm seeing, Kristen's pharmacy, and you teach people about the care you're going to give them. You see them in the office. You maybe aren't behind the cash register because they will still associate you with retail, like it or not, right? So Nova Scotia, talks a lot about that in their separate workflows and the way they've set up the pharmacy. So I think it's awareness, it's perception, it's marketing, it's branding. But people really do listen and really do believe it's special. I think that's a good point. I have 1 or 2 more quick questions. How are we doing for time? Are we okay? All right. Okay. So I want to talk about tactical things. So we have Minister Jones, who is standing at the back of this room. Welcome, Minister Jones. No, see, somebody turned around. She's not really here. She's got a wall of press behind her, and she says, okay, I've been listening to this panel, Sean, Nardine, Hitesh, Stacey. I've heard you, and, we're ready to move. I think some of you are actually meeting with political folks next week, so let's say they say that to you. We're ready to move. If I could change one thing, I can't do everything. We've got challenges with budgets. We're trying to deal with tariffs and Donald Trump and everything else. And health is sidelined for everybody right now. So that's a whole other conversation we could have about how we frame ourselves outside of health. But if there's one thing I could change, I've got a checkbook. I can write one check today. What is one thing that I could change to unlock your practice today? Stacey, I'll go with you first. One thing. So I have some money to give you. What is one thing that I could change that would unlock your practice today?
Well, my practice is very unique, but I think this also applies to pharmacy. I would say deprescribing. I think deprescribing should be funded. It's very unique. There's no financial gain to pharmacy. There's huge financial gain to patients where it's appropriate. Nobody's doing it or focusing on it in a way that's meaningful. And I can tell you, when I started this practice, I was kind of nervous, like, oh my gosh, what if I get a patient who doesn't have anything I can do for them? That has never happened in 4 years. So I would say deprescribing.
And I bet there's a lot you could teach a lot of people about how, when you say that's never happened in 4 years, every med review is an opportunity for that, and think about maybe you saved a fall, right? So there's other parts of the healthcare system. Hitesh, one thing.
I know Minister Jones really well. She comes to my store. We had this conversation last week. And the one thing that she will always push back on is, how do I sell this back cabinet? So we need to have a value proposition. How do we sell this back to cabinet? And so it's everything that we spoke about today. And she agrees that we need to expand the scope. We need to, a lot of what we need to do is advocacy. And, we have the Ontario Pharmacists Association that will do all this work behind the scenes, but we really need to, it's not about Minister Jones.
Yeah.
It's selling this to cabinet and then taking it to the next level.
Yeah. And hopefully it's an election cycle when she comes into your store and you have that patient beside you that says, this is how you sell it back.
The
right?
one other thing that I've learned with government is, you start getting into, a lot of advocacy work is about budget and budget cycles and how do you get behind a budget, right? So Justin, our CEO, has presented at budgets and he will go into a budget cycle and have a big presentation. We're not the only healthcare providers presenting here. There's, everyone has an ask, right? So it's a game of persistence. If it's not this budget cycle, it's going to be the next budget cycle. But then what's your plan between then? And then you have to regroup, reconvene, bring up advocacy in a whole different level, and then go back. But it's going to be one of the biggest messages that we have, outside of scope, is making pharmacy sustainable. How do we make pharmacy sustainable? It's this whole notion of our dispensing fee that has been stagnant since 2012, and bringing it, we're a chronically underfunded healthcare model. For them to catch up is $700 million. How do you go to government and say, this is what you're going to invest in? There's no way, you can't sell that. So I think it's a mix of everything that we're doing, and it's working. It's slow, it's budget cycle after budget cycle, and be persistent, support OPA, become members, and you will get there.
Okay, so we'll get that's a good one. Good plug for OPA. So if there is, and of course we know this is not how it really happens, but if the health minister is there, Nardine, and she has, Patrick Discerni is right beside her and he's ready to write the check, because we know that's what happens. What is the one ask? You have a patient with you. You've got one ask. We're going to make a decision on funding today. What is the one thing?
I would say OTC consultations, to fund OTC consultations, because I know that if we can fund those, then we will touch more people's lives, and the patient voice is ultimately what's going to drive a lot of the change. When OPA is out there doing their excellent work, and I agree, everybody join OPA. We need to make OPA strong as an association so they can make OPA great again.
Make OPA great again.
That's right.
MAGA.
I think that's necessary, but I think, if we do things, how many patients will go in and ask for an OTC? If you can get that consultation paid for, then they can see the value of the pharmacist in providing, care in that way, and then the patient voice is ultimately what's going to drive things. So when an OPA goes to Queen's Park and advocates for further scope and dispensing fee increases and all of that, it looks like it's self-serving, even though we know it's just to help the profession. It looks like that. But when a patient goes in there and does the same thing and says, I need my pharmacist to be able to do more to help me, then it's seen as a gap to access to primary care. So I think if we can reach more patients and maybe via OTC consults that are funded, maybe that's the way.
I think that's great. I think it's a bit of a village coalition idea, right? Bring the patient. Last night we talked about teachers, right? We talked about teachers who have the same hours as doctors' offices. Teachers would love to go see their pharmacist at 5 o'clock and get care that they can't get when the doctor's office is closed. So have others work with you and for you, absolutely. I'm going to take us, we only have 2 minutes left, so I'm going to take us to rapid fire. I'm going to start with Sean, so you don't know what these questions are. This is 1 or 2 words, okay? And if you'd say more, I'm going to cut you off. The service I'm tired of doing for free is, we're going to start here and go down. Sean? Stream of consciousness. Just don't think too much, Donald Trump. Well, he doesn't think at all of it.
Sending refill requests.
Okay, sending refill requests.
Refill
okay.
requests.
Tired of doing for free, Nardine? You just said it actually, didn't you?
Yeah, OTC consults.
Yeah, there. Okay, I gave you one.
Refills and adaptations for free. Every day in the workforce,
Yes.
every day.
Yeah.
I would just say admin.
Admin?
Admin.
Okay. Oh, yeah. Yes. Yes. Absolutely admin. Yes. Admin burden is real for all of us, right? Sean, the biggest roadblock in disguise. We talked about that a little bit. What's the biggest roadblock in disguise? 1 or 2 words. Come on.
Killing me with the 1 or 2
Yeah.
words. Going back to the question I didn't get to answer last is we need all of our reimbursement indexed to inflation
Oh, thank you.
back
Yes.
to when we were last given an increase.
Really great point, actually, that we didn't touch on. And many other countries, by the way, do this. Yeah. Not only are we behind a couple of decades and we're giving 2026 care, but getting 2000 and whatever it is, 12 dispensing fees, other countries, and I've presented this at World Forums where people say, you're not indexed to cost of living. Many other countries are, by the way. Okay, Nardine. Okay, well, I don't remember now. We're going to give you another one. The moment here's one. The moment someone outside of pharmacy finally got what we did, who was that person? Can you think of a person? Okay, can anyone? I'm asking you hard questions. Okay. Do you have one? The moment someone just got what we did. Like, you kind of answered it in the first question. Okay, we're going to go to another one. These are not, we're getting tired of these. Okay, you got one? Okay, awesome.
Yeah. Literally yesterday, I was sitting at a pub, and I was sitting next to a woman who's a mom who I know, and she just leaned over and said, thanks, one of my kids was in, and you went through and answered all those questions and put them totally at ease. And I'm like, and I just said, I did nothing special. And she said, you did exactly what you were supposed to do.
Right, I'm not just pouring from one bottle into another. And you said it before with we're all those special pharmacists, by the way. So your proudest pharmacy moment, does anybody want? Do you feel like you already had that one? Anybody? Okay, I'm going to give you a last question. In 10 years, here's the last question. Okay, rapid fire, anybody can answer it. In 10 years, the pharmacist who never stepped out of the dispensary will be remembered as? One word. One word? Sure.
Will not.
Sorry?
Will not be remembered.
Okay. Will not be remembered. Okay. Anybody else? So obsolete, non-existent, replaced by AI, all of the above?
The dispensing pharmacy.
The dispensary guys, you said something earlier I just want to say. We are not transactional, Sean, right? And it felt like maybe 20 years ago that was a little bit more evident, but it can be evident again. We have longitudinal relationships. We have relational care. We see people up to 10 times more, maybe more, than their family doctor. We have regular touch points. We don't have to say everything at every visit, right, Kristen? It could be 30 seconds, but 30 seconds every 2 weeks. That's a relationship, so really, really important. I want to thank our panelists. I know I really gave them, a bit of a hard time with some difficult questions here, but, I think we know that Amazon is coming. We know that the dispensary and the dispensing model, not yet, but at some point may go the way of the dodo bird in the way that we know it. We know that empathy and care and relationships and access and footprint matters in 2026, and the human side matters and will continue to matter. What the system needs to hear is what it costs when you're not there, the opportunity cost to you not being there, the things that people miss. Thank you very much, all of you, for joining me. I think we have a little bit of time for questions from the room. So I'll look around. If you have a question, stand up and I'll repeat the question for the live stream for our panelists. Yes, Nishan. Yes. Okay, so the question is, we have a whole new bucket of minor ailments that are coming at some point this year. That's the expectation. I'm going to look to Hitesh and Nardine. Do we have a timeline to when those are coming?
So the next round of, so it's the additional 14 minor ailments plus point of care testing. We are really pushing hard for a July 1st implementation. All our advocacy efforts are geared towards that.
Okay. Nardine, do you have anything to add? No? Okay. All right. Other questions?
I will say there's also OCP that has to work through some things at the board level for continuing education for 4 of the ailments or 3 of the ailments. And so that may delay things for those 3 ailments. But I think, everything's signaling a July 1st start date.
So some regulatory pieces. Yep, go ahead and ask your question. Okay, so I'm going to try to paraphrase for the live stream. So for Clinical Connect, if we can have it tagged to an individual pharmacist so that pharmacists can have access to the labs and everything that comes with that as an access point instead of being tied to the pharmacy. Anybody? I don't know the answer to that. So, okay. Do you want, Kristen says she's got,
Clinical Connect is a nightmare, and we're working on it.
And it's going to go the way of the dodo. We are working, one of the vice presidents at OPA and myself are on a working group for the DHDR with the Ministry of Health, and we are working on a comprehensive EHR for all patients across Ontario, and the onboarding will be much easier, and the goal is to have practitioners have individual access. Unfortunately, in my opinion, this is probably a number of years away, but we are aware of it, so I don't see a lot of work happening on the Clinical Connect front because that is being worked on actively at the ministry level.
Okay, so that's a good news story. There's a better solution coming, is what
There is
you're
a better
saying.
solution
Okay,
coming.
Awesome. Okay, can you stand if I have, I'm going to just stand up. Yeah, Siva, I think you're next, and then Kathleen, go ahead. Siva. Yeah, so the question, and it's a very good one, so I'm going to actually start with that and then give you, Hitesh, the mic. The question was dispensing should, the comment, then let me know if I paraphrase it correctly, the dispensing is a cognitive function and we need to recognize that. Is that fair that it has a clinic? And I actually think we should be calling it assessment of a medication rather than dispensing, but I think what we meant as a panel here is the more traditional, I would say the non-cognitive pieces of dispensing as we know it now will be automated in some way. There will always be the need for a pharmacist to assess whether this is the right medication for the right person at the right time, and the pharmacist is certainly the right provider. That is an element of dispensing. So let me just clarify, that's certainly what I meant, but others may have comments on
Siva,
that.
you're absolutely right. I think that's the essence of the dispensing fee, how we came about this dispensing. And you're absolutely right from an advocate perspective, not to negate that. What we're trying to do from an advocacy perspective is say the dispensing fee is not enough, because now we're doing more. We're doing more, and it's also all about workflow. So, when you talk about dispensing fee, it's sort of assimilated within the workflow. But now we're starting to do things that are outside of the workflow, and how do we get reimbursed for that? So that's the goal, but you're absolutely right. I think we need to keep that central to our theme, but continue to build on that, which is we're doing more. How do we build? So one of the big things that I spoke about earlier today is really having this discussion about, I can't afford to have a clinical pharmacist who's just doing minor ailments. You don't pay me enough to do that. It's not feasible. So I think on that same notion, you're absolutely right. So good point.
Dispensing is a core function of what we do. Sean, go ahead.
So, I love you, Siva, so I want to preface that. And I will pledge to you that I will never use and try to differentiate dispensing from a clinical cognitive service, as long as you will say that you will no longer use the word clinical pharmacist. Good.
Yeah.
Nope. So then we're completely aligned.
Yeah, everything we do is clinical. We talk about this a lot. We're actually not even allied healthcare providers. That's another bugaboo word that I have because it implies secondary. But anyway, there's a whole vocabulary and lexicon we could do. There was another question. So I think Kathleen first, and then you, Kathleen. Go ahead. Yeah, so I'm going to paraphrase the question first, and then you can answer. I think the question is around, can we get more public education or even other provider education on the on minor ailments, what it is and what it isn't, and some other pieces as well, because ultimately the frontline providers take the brunt of the patient's aggression, which we know happens all the time, and it is very difficult for our frontline providers, if I'm paraphrasing correctly, Kathleen. So we'll look at Hitesh, and I think Nardine will have something to say as well.
And it's very confusing for the patient. Think about the patient and what minor ailments can you prescribe for, what you can. It's central to our advocacy and what we're doing. I had a prescription the other day for a tetanus shot, and I had to call Siva and say, can I administer this? Because I had no idea. I couldn't figure it out. So it's central to our advocacy, and it's the impetus of going into full prescribing.
Nardine, go ahead.
I will say that it was part of the plan that OCP would be actually the one who carries out the public campaign, because ultimately they're there to protect the public. And so it was actually part of the MAG work. At the end, the implementation piece was they were going to conduct a public health campaign to notify the public of what it is a pharmacist can and can't do, and that did not happen, and there was a lot of change at OCP at that time. So that is something that I think we should be able to give that feedback back to the college and see what they could do, because that is ultimately their job. And I appreciate the association's efforts, but the association is to advocate for us as pharmacists, and I think this is definitely a college thing. And in other provinces, like in Nova Scotia, it is on the college to do a lot of that work. So I'd like to see that be done.
So you bring up a really important point in terms of advocating or using our voices. Perhaps it's sending a note to our regulatory body, and if others feel the same way in the room, could I be as bold as to say, send a note to your regulatory body? I'm looking at folks who are there now. I know you have a comment, but somebody else had a question, so I'm going to let her go first. Go ahead. So yeah, age-old question. So who wants to tackle that? That's a long one. So the question is around, I'll just repeat the question, around individual provider, I'm going to say billing numbers for the sake of brevity, which is really what you're asking, instead of remuneration going to the pharmacy. And we talked a little bit about this. I talked about it with somebody last night. So Sean, do you want to go first?
Yeah, this question has been around forever. And there's lots of different ways to answer it, and I don't know that there's a direct line at the advocacy level if there is work towards it. My usual answer is often one that people don't want to hear, but it's for one, it's your license number is your billing number, and you're attached to that and part of that involves a negotiation with your employer as to how you're compensated for the cognitive services you're employed, and that's the way around it, and it sounds like a cop-out in this circumstance, but you've got to, unfortunately, right now it goes through the pharmacy. The only other way to control it is to say, I'm going to go and open up my own pharmacy, and then I will have my own billing number. But I think it ultimately comes down to advocating for yourself with your employer.
I would also just add one quick comment. I know we're done, but I would not personally ask for that because, to be honest with you, from a business perspective, it's not enough. What the public funding provides for our services is not enough to make a business sustainable. You have to charge more to account for everything else that you need to run a business independently. And like many others have mentioned here, like dispensing also funds the pharmacy as well. Like it's not.
Hitesh gave the example of the $18. That is not enough to staff what a pharmacist has to do around that. So lots of great examples, but it's a good question and one that comes up a lot. Nardine, did you want to add anything to that? Okay. Any other questions? Yes, at the back. And Siva, I think you had another one, so I will. Okay. Two more questions, that's it, and then we'll be hanging around for a while. Go ahead. So the government is willing to invest. So we started getting into this conversation about how you frame things to government. But so government is willing to invest $1.3 billion into a tunnel, but how do we get them to invest in healthcare and pharmacists? Is that kind of your question? And see that as an important investment?
I'll be really honest, it's really technical, and it's working with the budget. Going behind a budget cycle and being out there. We're not the only ones asking for more. There's so many other players asking for more. So it's being part of that budget cycle. It's having the right people in government. It's having the right advocacy firm. We deal with Enterprise. That's a big sort of lobbying firm. Dealing with government is technical, and that's what it takes. It's technicality. We need to get behind a budget cycle. We need to have that funding allocated to a budget. We need that commitment. It's hard.
I think I'll just add one thing to that too, is I think you have to also think about government's problems of the day. There is so much going on in the world, right? There's so much going on in the country. People are worried about tariffs and most favored nation and CUSMA and all of these other elements. So I think two things. One is thinking about taking a whole of government approach, because community pharmacy is business and healthcare. So are we talking to health? Are we talking to small business? Are we talking to business? There's a whole of government sort of approach to this, because we're not just healthcare, but we are employers. We contribute to the GDP. There's a lot of other things we do for our communities. So I think framing in a way that's going to resonate with government is just strategic advocacy in terms of, you know, what your associations are definitely doing that for you, but I think what is the problem you're trying to solve, what's keeping you up at night, and how can we actually help you? We are also a business, we do a lot for our communities, it's not just health, so I think we have a unique value proposition there as well.
The Ford government is all about opinion. It's all about votes, and they're a very progressive government, so you can influence it at your local level.
Any other questions? I think that's it. We got it. We're way over, but clearly there was lots of engagement. So thank you once again to this fantastic panel for doing this on a Sunday with me. It was a lot of fun, and I'm sure we'll be around for a few minutes if you have more questions.
Round of applause, please. Round of applause. Wow. Last year, we had this. It's funny. We had this problem last year when we did the panel, and we felt like we could go on for another hour. I even had allotted more time this year, but I feel like, again, we can sit here for another 2 hours. And I think, you know, what comes out of this is how important it is to support OPA. PANP, we don't take dues. We say pay OPA because, you know, who knows that there's a 12-year fight for minor ailments. Like all the things that are behind the scenes that we don't see, you know, support OPA because we're going to get the things that we have. So if you're not an OPA member, you know, you have till midnight tonight to sign up. But anyway, no, thank you, Sheli, Sean, Nardine, Stacey, who came in, you know, last second, and then Hitesh as well. That was an excellent panel, and, you know, it's live streamed. We can play this again. I can watch this over and over. So thank you, everybody. We're just going to quickly move on. We have our closing remarks coming, but before I introduce Amy, I'm going to bring up Matthew. He is our winner of our annual scholarship, the Daniel Fiedler Memorial Student Scholarship. It's something that we like to give back to our students. If any of you have students that you work with for next year, please remember to tell them to apply. And it happens to be that Matthew is a student for one of our board members, Dattani, so I'm sure he's going to be very happy with that. So round of applause for Matthew, please.
Give you as much as we could.